PowerPoint will detail common problems experienced by patients that have a hemiplegic upper extremity. Treatment for patients that have a hemiplegic upper extremity should be in a team approach. For example, both PT and OT can work as a team to help rehabilitate the upper extremity. Just because occupational therapy ordinarily works with the upper extremity does not mean that PT should leave it out of their treatment session. As a therapist, you want to treat the whole person as much as possible. In order to be able to do this team approach, communication is absolutely key. You should know what the occupational therapist is doing in their treatment session so that you know not to duplicate their efforts during your treatment session, but to work on another activity that could be beneficial for the patient. Also realize that pain in the hemiplegic upper extremity is not normal. Even though pain is not normal in the hemiplegic upper extremity, shoulder pain occurs in 70 to 84% of patients. This pain is typically present with movement, but may be evolved to be present at rest also. Typically, the shoulder pain in this patient population is caused by some form of subluxation. This slide shows a cartoon of a patient with an inferior subluxation of their right shoulder. The inferior sublux is typically due to a lack of active movement. As you can see, the scapula is rotated downward with the glenoid forming fossa pointing downward as well. This results in stretching of the soft tissue around the shoulder and the capsule, and there's typically a loss of passive locking mechanisms for the shoulder. Another kind of subluxation you may see in this patient population is called an anterior sublux. In this case, any new control or muscular control gained by the patient is unbalanced. The downwardly rotated scapula is not seated properly and is pulled superiorly. Also, you may see extension of the humerus with internal rotation, and this causes the shoulder to sublux anteriorly. Another kind of subluxation you might see is the superior sublux. In this condition is usually caused by the flexion synergy of the upper extremity or the increase in tone of that upper extremity that can happen long after a stroke. You may see elevation of the shoulder with the scapula itself elevated and abducted. The head of the humerus becomes pressed up against the acromion because of the flexion synergy, and there's a lack of isolated humeral versus scapular movement. This kind of position often leads to impingement. Essentially, impingement in this patient population is caused by increased spasticity, a superior subluxation, muscle imbalance, as well as loss of scapulohumeral rhythm.